Hello, students, and welcome to the first lecture of Health Studies 130, Foundations of Health Studies. And this is going to be an introductory lecture. You should have already watched the lecture that explains how the course works and how I explained various job prospects for people who study health studies and a number of other things we discussed. So right now we're going to discuss basically a historical overview of health studies, epidemiology, public health policy, and so forth. And so just sort of relax, and we'll pretend that we're tourists going through a historical tour of public health, epidemiology, and health studies. All right, I explained in the previous lecture that health studies is a relatively new academic discipline that combines uh, aspects of other health disciplines or aspects of other academic disciplines that people have traditionally studied in the past. So if you took, for example, if you were an economics student, you would take a first year economics course, and as a first year courses tend to be what are called survey courses, which means you kind of take a wide you have a wide survey of topics in this academic field, but you don't go into any great depth when you're studying them. It's just you're going on a tour. You know, when you go on a tour of you go on a bus tour of Europe or something like that, they load everyone onto a bus, and then they start out and they take you to England, and they say, look, oh, everyone gets out of the bus and they say, look, there's Big Ben, the clock there, the Parliament buildings, there's the Tower of London. Okay, everyone back on the bus. You go over to France and you say, okay, there's the Louvre, there's Fontainebleau, there's this, that, and the other thing. Back on the bus. Then you go to Italy, off the bus. Look, there's the Leaning Tower of Pisa. There's Vatican City. There's the Roman Colosseum. Back on the bus. And then so you get a sample of all of these countries without really going into much detail or much of their history. That's sort of what we're doing with first year courses at university when we have a survey course like this one. So in the past, when you took a first year course in economics, you'd discuss a bunch of different topics as they relate to economics, and you would spend maybe 1 week or something like that discussing the economics of health. And then you go to your psychology class, you would discuss different aspects of psychology every week, and then you would spend 1 week dedicated to studying health and psychology. And then you do your anthropology course. You spend 1 week discussing health and as it relates to anthropology. And then eventually somebody said, you know, health is quite important. The study of human health is a very important thing. Study of human health and illness. So why don't we combine all of the, why don't we combine the week that we get in economics and the week that we get in psychology and the week that we get in sociology having to do with health, and combine them into a separate course and combine them into a separate academic discipline. So that's what we're doing. So health studies is basically the introductory level health studies courses are taking the aspects of related to human health and illness from economics, from psychology, from sociology, from history, from biology, epidemiology, public health policy, put them all into a single academic discipline. So health studies combines economics of health, psychology of health, sociology of health, the anthropology of health, the history of health, and so forth. Okay, so some of the major topics that we discuss within health studies, you should be familiar with these terms. First of all, you should know by at this point that pathology is the study of things that make you ill. Pathology is a branch of medicine. Medicine is a science dealing with fixing the human body, fixing and maintaining the human body. That is medicine. And pathology is a subdiscipline of medicine which deals with studying in a scientific way the things that make you sick. What is it that makes you sick? Now, when you look at a certain sickness, a certain sickness is usually caused when something about the human body breaks down. And when you understand all the different parts that broke down in order to give you that sickness, that is something called etiology, which we'll discuss later. But etiology is the study of the mechanism by which a certain disease makes you sick. What exactly goes wrong with the body to cause that illness? That is the science of etiology. And pathologists are people who, usually medical doctors, who try and study what is the etiology of this disease or another disease. Okay, medicine, as I said, is the study of curing things that break down in the body, fixing the body when it breaks down or malfunctions, right? Epidemiology is the study of illnesses, but not of individuals. It's the study of illnesses as they relate to populations. So, of all the people that get sick with a certain illness, maybe the epidemiologist does a little bit of detective work. They say, look, all these people are ill. What is it that's making them ill? We'll do some detective work and we'll ask, do they all live in the same neighborhood? Maybe that's the problem. Do they all eat the same type of food? Maybe that's the problem. Do they all have something in common? What is it that they have in common that we can use to figure out what it is that's making them sick? And that's generally what epidemiology is. There's a lot of in epidemiology. There's a lot of drawing maps to show the distribution of sick people and the distribution of illnesses throughout a population or throughout a landscape. There's a lot of drawing of maps. There's a lot of plotting of graphs. By the way, in case you didn't know, you're supposed to plot, P-L-O-T, a graph. You don't draw graphs, you plot graphs. So in epidemiology, there's a lot of plotting of graphs, a lot of analyzing statistics, but the main difference between epidemiology and medicine is that medicine deals with individual patients and epidemiology deals with sicknesses as they are distributed within a large group of people or in a large landscape. As I mentioned in the previous lecture, public health is where you take epidemiology and medicine and you put it together into laws that benefit the public in terms of their health. Is there anything that a certain group of people within a society is doing that raises a threat, that poses a threat to other people in the population? Are they spreading diseases? Are they subject to diseases? And we have to be more careful with a certain group of people because they are more vulnerable to diseases. And then we make laws that prevent, that increase the public health and decrease the possibility of getting diseases. That all relates to a topic called public health, which is related to government policy. We elect governments who then hire experts, doctors and epidemiologists and pathologists who give the government advice about what laws you should make in order to keep the population healthy and what laws you should make in order to prevent illnesses. Public health and epidemiology traditionally dealt with what are called communicable diseases. A communicable disease is basically a catching disease, a disease that you can catch. And so in the past, traditionally, epidemiologists and public health officials have dealt with public health crises or public health emergencies that relate to communicable diseases like smallpox or polio or COVID-19. These are all diseases that you catch from other people or from other organisms, right? These are diseases that you catch. In the last 50 years or so, epidemiologists have also concerned themselves with non-communicable diseases. So, for example, diabetes is a problem with the pancreas, the human pancreas, and it's not something you catch. Depending on which type of diabetes you have, diabetes type 1 or type 2, it's not even a type of diabetes that you inherit. So there are some diseases that you inherit from your parents because of a flaw in their genes, right? So those are non-communicable. You don't catch them. You inherit them. Or there are many problems like heart problems and other liver and kidney problems. There are other problems that you just get, but it's not the result. It's not the result of something that you can catch. It's not the result of a virus or a bacteria or a fungus. It's the result of perhaps toxic substances in the environment, perhaps use and abuse of the human body to do things that the human body was not meant to do. There are lots of things like that that you do not catch, right? So if your brother has diabetes and you share the same room with your brother who has diabetes, you don't have to worry about catching the diabetes from him, do you? Diabetes is a non-communicable disease. But anyway, people who are concerned with the health of a population, and then is there anything that the government can do to prevent the spread of illness or the occurrence of illness, they can put that into public health care policy. Okay, now finally, just in the last few years, probably in the last 20 or 30 years, the science of health sociology has come about. And health sociology, of course, is the study of societies. How do we organize our civilizations into groups of people that do certain things? People have a profession, they have family units, they have religious beliefs, they have all of these things. All of these things contribute to the society that we live in. And you know as well as I do that different societies are different from one another. Different societies tend to be slightly different than one another. They have some things that are in common that they do that are similar to one another, and they have other things they do that are different. You put all these factors together, the behavior of human beings when they form a large group called a society. What does that have to do with health? Well, it turns out that the way we organize our societies has an impact on health as well. So I mentioned in the previous lecture that if you have a very stressful job, if you're forced to do a very stressful job in order to earn a living, you tend to be less healthy than people who have other jobs. If you like what you do for a living, if you love your job, you tend to be much more healthy than if you hate it. If you hate your job, you tend to be sick a lot more. And so the employment and meaningful employment is a sociology factor that makes an impact on your health. So health sociology is the study of all of those things. Health sociology is the study of the social determinants of health, the social determinants of good health. So remember that a determinant is something that determines whether something will happen or not. So are there things about our society that will determine whether you get sick or not? We call those the social determinants of health. What is the difference between health science and health studies? Nothing really. They're both dealing with the same subject. They just deal with it in a slightly different way. So health sciences tends to put more emphasis on the science part, and there's more medicine in health sciences, more emphasis on statistics and what healthcare professionals need to do, more graphing, more math. And then health studies generally is considered to be an arts. The main difference between studying science and arts at the undergraduate level, if you do not yet have a bachelor's degree, you're considered to be an undergraduate student. So at the undergraduate level of education, the main difference between health sciences and health studies is that health studies is for non-science students. So people who are more interested in there tends to be more emphasis placed on the sociology of health in health studies than there is in health sciences. So the health sciences care more about microorganisms, viruses versus bacteria. The health sciences care more about mathematical equations and statistics and plotting graphs. The health studies cares more about the impact of the way our society is built on health. In short, health sciences has more math, health studies has less mathematics. Other than that, it's sort of the same. When I was at Simon Fraser University, for instance, I did a geography minor. And when I was I did a Bachelor of Arts at Simon Fraser University, and then I went to UBC and did a Bachelor of Science. And there was a difference when I was at Simon Fraser studying. When I had a geography minor and a psychology major, the geography minor, you could take geography as either an art student or a science student. If you took it as an art student, you took geography courses and then you took other courses in psychology and things like that. When you did geography as a science student, you took the same geography courses that the art students did, except that then you went off and you did a calculus class and a statistics class instead of a anthropology class and a sociology class. So the arts and science students tend to study slightly different things. Health sciences is usually something that a science student would study. Health studies is something that's more arts oriented and contains less mathematics and so on. But in both cases, it's necessary to know at least a little bit of mathematics, and it is necessary to understand some basic statistics and what they mean. As I said before, I promise to make that as painless as possible, so we're not doing a lot of it. Okay, so in this course, the first part of the course is going to be on epidemiology and public health. It's going to focus on epidemiology and public health, and then the second part of the course is going to move into more sociology, the social determinants of health. So in the second part of the course, we will talk about your socioeconomic status as a determinant of health or illness, and your gender as a determinant of health or illness. Um, Gender, for instance, plays a very strong role in whether you're healthy or not. In fact, so the data indicate that women are subject to more diseases throughout their lives than men, and it is true that the female body is more complicated than the male body, particularly the reproductive system. The male body is fairly simple, especially the reproductive system. So, because the female reproductive system is more complicated than the male reproductive system, there are more things that can potentially go wrong with it. But even if you exclude those things, if you exclude problems with the male versus female reproductive system, and you just consider the illnesses that men and women have that are not related to their reproductive systems, women still get sick more often. To be more precise, women tend to visit the doctor more often, and then so men have a shorter lifespan, women have a longer lifespan, but those years are sicker. They spend more of their lives being sick. And there are some theories in health sociology about why that would be. Why is that? Some of it is to do with the fact that men tend not to go to the doctor because they don't like to. Women, when something goes wrong with their body, they want to have it fixed. Men generally, if something goes wrong with their body, they tend to just grin and bear it, as they say, and not see the doctor until something is very wrong. So small things, women tend to go to the doctor to have them dealt with sooner, and men tend to let things go a lot longer until things get really bad before they see a doctor. Now, from a public health perspective, that's not actually good for the men to not see the doctor when something is wrong, because it is economically it's less expensive to deal with illnesses when they are small, when they're at the beginning. So it is better to have illnesses dealt with when the problem is small, rather than waiting until it's large. So in that sense, women are better. The female way of dealing with the healthcare system is a better strategy. All right, so in other words, also in the first part of the course, we're going to be dealing with more with the question of what is illness, and then in the second part of the course, we're going to be asking the question, what is health? There is a difference between the way these two problems are approached. It's fairly easy to define illness, right? It's fairly difficult to define what is good health. What is the best possible health, or what is optimum health? So we will deal with both of those questions. All right, so in part one of the course, we're going to deal with epidemiology and public health. We'll ask what is illness? What kinds of illnesses are there? What is the physical basis of illness? How are illnesses distributed? We'll talk a little bit about that. What can we, the people, or the governments that we elect, do to prevent illnesses? And are there some things that government shouldn't be able to tell you what to do? If we could prevent a lot of illnesses from spreading if government had total power to tell people exactly what they can and can't do at all times. But we don't want to live in a society like that. So we live in a democratic society where the power of government is limited, deliberately limited. And so there are some things that each of us is allowed to do that may be stupid, that may endanger others. But that's part of living in it. That's one of the things that you have when you live in a free society. In the second part of the course, we're going to deal with factors that determine whether you have optimal health. By the way, the term that we're going to be learning in the second part of the course is called salutogenic factors. Salutogenic factors are things that you do or things that you're exposed to that happen to give you better health, that tend to improve your health, right? And then the second part of the course, we will deal more with social and economic determinants of health. So in today's lecture, I'm going to just give you an overview of what we're going to talk about today. And number one is I'm going to tell you about who employs epidemiologists and public health officials. So if you go on to become an epidemiologist or a public health official, these are the people who would hire you. To be honest, there are not a lot of jobs for epidemiologists. There are only a few epidemiologists, and they are employed by the government. So if you're planning on becoming an epidemiologist, you should be aware that the job prospects are very poor for that profession. However, it is even if you're not going to be an epidemiologist, it's very useful for you to know about health and illness, and so that's basically what this course is for. This course is for the majority of people who take this course are taking it to increase their knowledge of how health and illnesses work, which is an important topic. But only a few of you will ever become epidemiologists, and that's just the way it is. In the second part of the course, we're gonna go through a historical tour of the history of public health and epidemiology, and look at some of the historical examples of how this science came to be. And then in the third part of the course, I'm going to give you some modern examples of public health and epidemiology. Okay, so let's talk about these. Okay, so as we said many times, epidemiology is the study of the causes and distributions of illnesses within populations rather than individuals. And public health is using epidemiology, the knowledge that we get from epidemiology, to craft government policy designed to improve public health and minimize illnesses. Here are some examples of terms that you need to know. So first of all, a mandate is a law that says you have to do something. Right? A law, the government makes a law that says you must do this. You have no choice. Governments in democratic societies like ours tend to resist making mandates because the public doesn't like to be told what to do. So if you're a politician, you don't want your the pol you don't want to be telling your constituents, the people who voted for you, what to do, because then they will vote you out next time. Right? So governments in democracies tend to resist creating mandates. Codification, to codify something, means to put it into law. So when you make a legal mandate, you have to codify it, right? And lawyers are very legal language must be very precise, right? So when you decide that you're going to make a mandate that says people have to do something, that's fine. That's an idea. But when you codify that idea into a law, you have to be very careful about the language, because lawyers like to pick apart laws and say, well, you didn't specify this, so that means that it's all right for me to do this because you didn't put it into the law that I can't. And you said here that I have to do this, but you didn't specify exactly how I have to do it, so I'm going to do it this way, which is not what you intended when you wrote the law. So there's a difference between making a mandate and the codification of public health policy into law. Mandates are laws that force you to do things. They are generally, when you make a mandate, you have to codify it into law. You put it into the law, and then you have to be very careful with the legal language. So, for example, on quizzes, we're going to have a quiz starting next week. The quiz is based on this lecture. Right, so study this lecture, and either next week or the week after, we will have our first quiz, and it will contain questions from this lecture. And so I could ask you, what is a mandate? Right? So a mandate is a government law that says you must do something. You have no choice but to do it. On the other hand, I could say, what do you call a law that says you have to do something? By law, you have to do something, and you'll say, well, that's called a mandate, right? And then what does it mean when you write a mandate into a law, or when you write a law into the legal code of Canada? What's the definition? What word do you use to describe that? And the answer is codification. You codify the law. Okay, now there's a difference between a mandate that is codified into law and something called a condition of employment. So you need to know what a condition of employment is as well. A condition of employment is, right, so I just mentioned that governments don't like to make mandates because mandate is you have to do something, you have no choice, right? And people do not like to be left with no choice. The government says you have to do this, you have no choice, I'm telling you. Right? People don't like that. So instead, there are some other things. There are some other things that are sort of like a mandate, but they're not compulsory. They're only compulsory if you intend to do a certain thing. And if that's the case, you still have some freedom whether you're going to choose to do that or not. So, for example, best example is the nurses and doctors who work in hospitals generally have to be vaccinated against any illnesses that they might be exposed to in the hospital. The reason for that is if a nurse or a doctor is allowed to work in a hospital where there is a smallpox outbreak, for instance, and you did not require them to be vaccinated against smallpox, there is a vaccine that prevents you from getting smallpox. Some people don't like vaccines. Some people don't like needles. They don't think vaccines work, which is actually not true, but they do work depending on the vaccine. But some people don't want to be vaccinated, and so you say, well, okay, you don't have to be vaccinated, but you can't work at this hospital unless you are, right? It is a condition of your employment, right? So nobody's forcing you to work in this hospital, but if you choose to work in this hospital, as a condition of employment, you must be vaccinated against smallpox. I used to work in a hospital, and most hospitals have a rule that you have to be vaccinated against hepatitis B. Hepatitis B is a virus that destroys the liver. And if you work in a hospital, you come into contact with human blood from people who may have hepatitis B, and so if you poke yourself with a sharp object or something, and you get some of their blood on the wound that you've created, if some of the patient's blood gets through your skin due to a cut or a poke from a needle, you could get hepatitis B unless you are vaccinated ahead of time. So for most working in most hospitals, they have a condition of employment that says you have to be vaccinated against hepatitis B. So when I worked in this hospital, I had to have hepatitis B vaccinations, and I had to show the employers that I had been a card that said I had been vaccinated. It's the same for a lot of things. Now we had during the COVID-19 pandemic, there were some nurses and doctors who worked in hospitals who said, I don't want to take the COVID vaccine because I don't trust it. The COVID vaccine was relatively new, and most of the hospitals said, okay, you have to, it's a condition of employment that you get it. And the doctors and nurses that didn't want to get it turned around and said, wait a minute, when you hired us, getting a COVID-19 vaccine was not a condition of employment. Now you're saying that it is. So you're changing, excuse me, you are changing the conditions of our employment halfway through. You're changing the conditions of our employment midway. That's not legal. You can't do that. And so we had these large court cases where people who worked in hospitals but didn't want to get the COVID-19 vaccine took the hospital to court. In the end, what they did was they actually the hospitals gave the people a choice, and they said, okay, you don't have to get the COVID-19 vaccine, but if you don't, you have to be tested for COVID every day or every other day. And so it still it left the people the choice of getting the vaccine or not. Probably half the people that didn't want to get the vaccine got it after that ruling, after that court ruling, because they said it's too much trouble to get tested for COVID every single day or every other day. I'm just going to get the vaccine and hope that it's safe. It is actually safe, despite what you may hear in social media sometimes. It is actually very safe. Now, there's something, so that is the difference between a mandate, codification into law, and a condition of employment. Condition of employment says you have to do this, but only if you plan on doing that, something else, right? So if you're going to work here, you have to have the vaccine. You don't have to work here if you don't want the vaccine. That's a condition of employment. Okay, now, tax policy. You know that one of the main things governments do is they write something called a tax code, and the tax code determines how much taxes you pay and where you pay it. We have sales taxes, right? And we have income taxes. So income taxes are where they take the money out of your bank account from your salary, from your work. And then sales taxes are when you go and buy something, the item that you buy actually costs more than the price tag says, because on the way out they charge you a sales tax. They also have other types of taxes. So the way the tax policy is written in every country is unique, and it is often in many cases the way the tax code is written. It is easier to write a tax code that puts a tax on something that you don't want people to do. It's easier to raise the taxes on an activity that you don't want people to do than it is to try and make a mandate that says they're not allowed to do it, right? So When you do that, we sometimes call those things sin taxes. A sin, is kind of a religious word meaning things that you're not evil things that you're not supposed to be doing. It's bad to do these things. We call that we have a slang term for that when we call them sin taxes, right? So for sin taxes are often applied to things that we don't want people to do, such as cigarette smoking, right? So we're not making a mandate. We're not using a mandate and codifying into law that cigarettes are illegal. That would be very difficult to do in a democracy. But it's very easy for governments to raise the sales taxes on cigarettes. And so there are two reasons why the Canadian government does do that. For instance, they have a very high sales tax on cigarettes because they don't want people to smoke, because smoking causes lung cancer. That is not controversial, by the way. It's a proven fact that cigarette smoking causes lung cancer. And not just in the people who are smoking. It causes lung cancer in the people who are living close to those people, right? So you inhale smoke. When you exhale it, it goes into the room, and then other people inhale the smoke as well, and then we call it secondary smoke. Right? So if you smoke, you're doing damage to your body as well as the bodies of other people who are near you, and so they don't want you to do that. But they have never made a mandate against smoking. They've never said it's illegal to smoke. What they do is they add some very high sales taxes onto cigarettes, so to discourage people from smoking. They also put large sales taxes onto alcohol, right? So because alcohol ends up doing a lot of damage with people who drink and drink irresponsibly, do irresponsible things like getting drunk and then driving their car and killing people. That too is something they don't want you to do. So the government would prefer it. From a public health standpoint, they would prefer it if you didn't drink, but they didn't want to make that illegal. In fact, in the United States, they tried that in the United States during the 1930s, something that was called prohibition. And instead of discouraging people from drinking, it just turned the production of alcohol into a criminal enterprise. And so they had these notorious gangs of people that were called bootleggers that manufactured illegal alcohol and sold it illegally on the black market. Anyway, so in Canada, we have a very high sales tax on cigarettes because the government doesn't want you to smoke cigarettes because it causes health problems, and when you have lung cancer and things like that, all of us have to pay for it, right? Because we have a public health care system. Now, the other thing is, this is another term that you need to know called a Pigovian tax. Pigovian taxes. So there was an economist named Pigovy, I believe. That economist invented this term, and what a Pigovian tax is, you need to know this for public health policy. A Pigovian tax is where a business does something, a business sells you a product, and that product does damage to other people, but the business that sold you the product will never feel that damage, right? The business is selling you something that causes damage to the society, and somehow the company that makes that product should be made to pay for the damage that it causes, right? And so you put a tax on them because you put a tax on them in order to offset and compensate for the damage that they're doing to your society. And that is called a Pigovian tax. So in Canada, every year, the Ministry of Health does surveys, and they ask people, do you smoke, yes or no? Did you quit smoking, yes or no? If you quit smoking, why did you quit smoking? Was it because cigarettes were too expensive, or was it for some other reason? And the result of these surveys is that the Canadian Ministry of Health every year is able to calculate how many people quit smoking because of the taxes. And so therefore they're able to calculate how much, are the taxes not high enough? Are the Pigovian taxes on cigarettes not high enough? Should we make them higher? Should we make them lower? And then the money that we collect from the sales tax of those cigarettes, we put it into the healthcare system to offset the cost of treating people with lung cancer due to cigarette smoking. Right? So you need to know what a Pigovian tax is and how Pigovian taxes are sometimes used to address public health problems by governments. Another example of a Pigovian tax is a factory that pollutes the water supply. They dump toxic chemicals into the river. The government is forced to pay the bill to clean up the river, and but they shouldn't have to. You shouldn't have to pay for a mess that you didn't create. And so they charge a Pigovian tax on the product that, if you have a company that makes plastics, they tend to put a lot of toxic chemicals. The production of plastics generates a few toxic chemicals. Some places dump that into the ocean or into the nearby lakes. The government has to be careful and sometimes has to clean up their mess. And so they put a tax onto the plastics that they create in order to offset the cost of having to clean up the mess that they made. So that is a Pigovian tax. All right, choice architecture is a relatively new example of public policy, and it is where government doesn't tell you what you can and can't do, but government, through their research, knows that there are some things that it's good to do and some things that it's bad to do. So, for example, bad to do would be cigarette smoking. Good to do, something that's good to do would be cardiovascular exercise, like riding a bicycle or running on a treadmill. Those things, if you spend just 20 minutes a day on a treadmill, or 20 minutes a day riding a bicycle, or 20 minutes a day on a Stairmaster, something like that, it will have a significant impact on your health. It will improve your health greatly. Right, so that's a small bit of activity that you can do, which will greatly improve your health, and then you will get sick less often, and that will be less of a drain on the public taxes, because we don't have to pay to fix. Everyone doesn't have to pay to fix your illnesses that are the result of a sedentary lifestyle. The word sedentary lifestyle means somebody that spends all day on the couch, sitting all day, rather than being active. So what they do is governments don't want to make a mandate that says we're going to force you to get on the treadmill every day. But what they can do is they can write the tax code so that you can deduct, if you buy a treadmill for your home, you can deduct that from your taxes, the tax money that you have to pay. And so that's a choice that you make, whether you want, but they're not forcing you to buy a treadmill and use it. They're giving you an incentive to buy one. And then whether you use it or not, that's another matter. Many people don't. But anyway, another example is if there's so choice architecture is a very interesting field, because what you're actually doing is you're finding ways to craft government policy that make it easier for people to do the right thing and harder for people to do the wrong thing. So I already explained that when they put sales taxes on cigarettes, they're trying to encourage people not to smoke, but they're not banning cigarettes. They're not making a law that says you can't smoke. So putting a tax on cigarettes and saying, if you still want to smoke, go ahead, but it's going to cost more money. And a certain number of people will say, well, I'll forget it. I don't like it that much. So that's an example of choice architecture, which is today working its way into government policy. Many government policies regarding health are based on choice architecture, creating an environment that makes it easier for people to do the right thing and harder for them to do the wrong thing, but without actually telling them what they can and can't do. So, for an example, a good example, I might ask you to give me an example of mandated health policy. When's the last time you saw somebody riding a motorcycle without a helmet? Probably not very long. Probably you've never seen somebody riding a motorcycle without a helmet, because it's been a mandate. They mandated wearing helmets on motorcycles about 50 years ago, or 60 or 70 years ago, I believe. So it is illegal to ride a motorcycle without a helmet, or a scooter for that matter. And um, in the old days, this is kind of a macabre thing to talk about, but in the old days, when people need organ transplants, you need a heart transplant, you need a liver transplant, something like that, and then you ask the question, where do you get the hearts and the livers and the lungs to transplant into people? And the answer is they used to get the vast majority of them from people who sustained head injuries in motorcycle accidents because they were riding a motorcycle without a helmet. And so they bang their head, the motorcycle falls over at a high speed, they bang their head on the concrete. That's usually enough to kill your brain, but in many cases your body keeps on working, the brain stem keeps on working. So people who are have their brain is dead, but their body is still working, their heart and their liver and their lungs and kidneys are still working, and then you can transplant those organs into people right away. People like that are referred to as being brain dead. Now, we used to get all of the most, probably 90% of the organs for transplant into people came from motorcycle riders who were riding without a helmet and got into a crash, which is very tragic. And as soon as they mandated the use of wearing motorcycle helmets, nobody's allowed to ride a motorcycle without a helmet. The frequency of people being brain dead from motorcycle accidents dropped by about 90%, and then therefore it also became so. On the one hand, that's great because we have fewer people dying or being seriously injured from motorcycle accidents, but on the other hand, now we have a lot of trouble finding organs to transplant into people. And so what we're going to do, what we are doing actually, is looking at ways to create artificial organs. And anyway, so that is an interesting idea. The fact that you can no longer ride a motorcycle without a helmet, that's the law everywhere, is a good example of a mandate that has been codified. If you ride a motorcycle, you must wear a helmet. Another good example of a codified mandate is the seatbelt laws. If you ride in a car, if you have a car, the car must be equipped with seatbelts. That's the law, and those seatbelts must be worn. That's the law. So, if you're driving around or riding around in somebody's car and you don't have the seatbelt on, a police constable can pull you over and give you a ticket for not having the seatbelt. And so, the wearing the seatbelt is a mandate. That's a good example of another good example of a mandate. What about bicycle helmets? Well, in some places it's mandatory to have a helmet when you ride a bicycle. In other places it is not. So this is kind of interesting. In Canada, it is universally mandated that everywhere in Canada you have to wear a motorcycle helmet on a motorcycle or a scooter. But in some places, and basically everywhere in Canada, you have to wear a seat belt. Right, so those are two mandates that have no exceptions. But there are regional differences for bicycle helmets, right? So there's some places in Canada where you can ride a bicycle without a helmet, and some places where you can't. In some places in Canada, it's mandated that you have to wear a helmet if you're using a skateboard, but in most places it's not, right? So you see people either with or without skateboard helmets. Okay, so what would be a possible reason why helmets would not be mandatory? Basically, just as I said, it's an infringement of your freedom, your personal freedom. So one of the interesting things about democracies, liberal democracies, is that they say, ideally, they say that it is you have the right to destroy yourself if you want. You have the right to make a mess of your own life. So you may be surprised in places like Vancouver where we have such a terrible drug abuse problem. Why don't they just do something about it? And a lot of some part of the answer is that we believe that, or we claim to believe that people have the right to make a mess of their own life, and they have a right to make irresponsible bad decisions with their life choices. And so that was always the reason why that, putting in helmet mandates for motorcycles and seatbelt regulations was controversial when it happened. And so we started. I remember it was probably about 1974 when the universal seatbelt mandate came in, and I remember a lot of people were against that. Now it's taken for granted, but in 1974, probably a third of the population was very very angry about the seatbelt mandate. All right, conditions of employment. Vaccinations are usually a condition of employment for working in a hospital. The main reason is not to protect you, by the way, it's to protect the other patients. Because if a doctor or a nurse let's say a doctor or a nurse is treating a patient who has COVID, and that doctor or nurse gets COVID from the patient and then they give it to another patient, that's a problem, right? And so that is why vaccinations against all vaccinatable diseases is usually a condition of employment for people who work in hospitals. So if I ask you to define a condition of employment, or I describe what a condition of employment is, you would be able to answer. Again, tax policy and Pigovian taxes and sin taxes, the best examples are cigarettes and alcohol. People who drink irresponsibly and then drive and kill people and cause accidents that cause bodily injury. And then we have to, with our universal healthcare system, we have to pay for it. Same thing for lung cancer. We all have to pay for to treat lung cancer patients. We believe that it's fair to charge a higher tax rate on this product to, number one, discourage people from using it without actually forbidding them from using it, and two, to offset, to collect money to offset some of the damage that the healthcare system has to pay for. Um, Choice architecture, interesting. If you, as I said, if you do just about 20 minutes a day of cardiovascular, anything that gets your breathing and your heart rate up, heart rate above 200, something like that, I believe, that will greatly improve your health. So that's something we encourage people to do using choice architecture, and I'll explain that in a minute. Okay, so choice architecture, you may not be aware that you are being subjected to choice architecture by companies and businesses all the time. So when you go into the supermarket, there are certain items that they want you to buy because they make more of a profit if you buy this type of olive oil versus another type. So you notice here they put the olive oil that they want you to buy at exactly eye level. Right? So that's a very common trick that supermarkets use to get you to buy certain products. They put the products that they want you to buy at eye level. They put the products that they don't make as much money on way up at the ceiling or way down on the floor, so you have to bend way over or get down on your knees to get the oil, the type of oil that they don't want you to buy. So generally they have the generic oils at the bottom of the shelf, and they have the oils, the very expensive retail oils at eye level. Another thing that they do, which is an example of choice architecture, is they put all of these magazines and chocolates and candies and gum and all these things that they want you to buy at the cash register, so that while you are waiting in line to pay for your groceries, you start reading these magazines and then you decide to buy it. So that's something called impulse buying. Impulse buying. And so the supermarket is manipulating your choices by creating a choice architecture, encouraging you to do what they want you to do by making it easier for you to do what they want you to do. So you're trapped like a cornered animal in the checkout with these magazines, and then you start looking at them because you're bored waiting to pay for your groceries, and then you buy it. Right? So that is an example of choice architecture. So if private interests like companies can use choice architecture to try and get you to do what they want you to do, the government can do the same thing, try and make it easier for you to do the right thing according to them. And in theory, government is supposed to be on your side. Right? So the government is supposed to be using choice architecture to make it easier for you to do things that benefit you according to their research. Here's an example. Potato chips and other crisps and other things like that are very high in something called transunsaturated fats. Transunsaturated fats clog the arteries and cause arterial, and they cause heart attacks. They cause atherosclerosis, and they cause occlusion of the coronary arteries and things like that. So those foods are actually quite bad for you. But they didn't ban them. They didn't say it's illegal to sell these foods that are high in transunsaturated fats. What they did in many places in Canada was they said, okay, if you're going to have a vending machine there that sells unhealthy choices of food, you should also have a vending machine there that sells the healthy choices, right? So you should be able to at least choose whether you want to buy food items that are very bad for you out of a vending machine, and the choice of buying foods that are better for you out of a vending machine. So that's a good example of public healthcare policy that is using choice architecture. These things, mandates, codification, and conditions of employment, are considered to be something called government hard power, because government has this extraordinary power to be able to tell you what you can't do. That's not to be taken lightly. So we kind of like they call that hard power. Soft power is where they try and influence your choices and try and influence you to do the right thing without actually forbidding you to do bad things, or forcing you to do things that they consider to be good. All right, just because I promised I would say this, who employs public health officials and what do they do? Okay, who employs epidemiologists for public health? The main employer for epidemiologists is the government of British Columbia and the government of Canada. This is the Canada Job website. I was looking at it a while back, and I saw this advertisement for epidemiologists. Notice that they want somebody who has a PhD or a master's degree in epidemiology, and the starting salary is between $70,000 and $100,000 a year. Right, so the government does employ some epidemiologists, not a lot. Right, so you should be aware that you can train to be an epidemiologist, but that won't necessarily guarantee employment. As I said in the introductory lecture, if you want guaranteed employment, you should become a nurse or a doctor, because those people are in such high demand that they will never want for employment, never. So if you want guaranteed employment, become a nurse. That's usually the best thing to do. There's a severe shortage of nurses, and so I can guarantee that you'll get a job as a nurse. It just may not be a job that you want. It might be you're on the night shift, or you work in a clinic that's in a part of town that you don't like, or something like that. But I guarantee you'll get employment as a nurse. All right, so what about government agencies that employ public health officials and epidemiologists and things like that? So I'm going to draw your attention to four different agencies. The CDC, the Center for Disease Control, is an American research institution that's paid for by the American federal government. The Centers for Disease Control and Prevention is what they're actually called. The CDC used to be the premier, the number one most trusted and most influential health organization in the world. I have to say that the current United States government is destroying it as fast as they can, which is a tragedy, because it was such a superb organization. The World Health Organization is paid for by the United Nations, and it deals with the health of the world, whereas the CDC deals with the health of Americans only in the United States. The World Health Organization is more concerned with the health of everyone in the world. The World Health Organization, by the way, is financed by the United Nations. The United Nations is a voluntary organization, which you may have heard of. I won't explain it anymore, but you can look it up. It's a voluntary organization that kind of deals with international affairs, but they actually have no power to do anything to individual countries. But the United Nations is paid for by the member states, the countries that belong to it, and each country gives a fraction, pays for it according to how strong their own economy is. So richer countries pay more money to the World Health Organization, to the United Nations. Well, these countries pay money to the United Nations, and the United Nations allocates a certain fraction of it for the World Health Organization. So the World Health Organization is the second biggest and second most influential and useful public health organization in the world. It is paid for by the countries that belong to the United Nations, according to the strength and wealth of their economy. At the moment, the United States has the largest economy in the world, so they pay the most for the World Health Organization. The second largest economy in the world is China, and they pay the second largest amount to maintain the World Health Organization. Canada has a relatively small economy because we're a relatively small country, and so we're way down the list. We're probably number 10 or number 20 or something like that. But payment for the World Health Organization is based on the strength of the economy of the member state. The Public Health Agency of Canada, the PHAC, is the Canadian Public Health Organization for the federal government, not the provincial government. And the BC CDC, the British Columbia Centers for Disease Control, is the local public health agency, which is located in downtown Vancouver by Vancouver General Hospital. And it's a smaller organization, so it has a very small budget. All right, so these are the various logos for these organizations. And you can also see the various budgets. Sorry, the BC CDC is kind of obscured, but the budgets for these organizations are: the Center for Disease Control in the United States has a budget of $11 billion, which is very large. The World Health Organization has a budget of 4.4 billion, which is a lot smaller. And the Public Health Agency of Canada has a budget of 600 million dollars, 0.6 billion. And the British Columbia Centre for Disease Control has a budget of $70 million, which is quite small relative to the others. So in the past, the CDC used to do a lot of very, very interesting, important research that was transferable to other countries. I mean, it was meant to investigate how to prevent diseases in the United States, but the information could be used by a number of other countries as well, and so we traditionally we did. Okay, and now who is in charge of these various organizations? Well, in Canada, just focusing in on Canada, the BC Minister of Health, the Minister of Health is a member of the provincial government. This slide is a little bit dated, but up until last year, the Minister of Health was a man named Adrian Dix, who you will see on the news every now and then. And the BC Chief Medical Officer until last year was a woman named Dr. Bonnie Henry, who's a very interesting and a very distinguished, very influential physician. And the federal Minister of Health was someone named Mark Holland. And then the Chief Medical Officer of Canada was a woman named Theresa Tam. I will not ask you about all of those names on tests. I will not ask you who they are because they change every few years. But those were people who were in charge of these various local organizations, including the Public Health Agency of Canada and the British Columbia CDC. Okay, so this is Bonnie Henry at the podium. You might see her on television occasionally. She was until just a few months ago, she was the Chief Medical Officer of British Columbia, and standing behind her is Adrian Dix, who was until a few months ago was the British Columbia Minister of Health. Now, Bonnie Henry, the BC Chief Medical Officer, is a very interesting physician. She's a very good, very experienced public health agency official. She used to be a doctor in the Canadian Navy for 20 years, and then when she retired, she went back to university and got some more qualifications and became an epidemiologist as well as a physician. And so she was actually quite very well qualified for that position. This is just an old photograph of Bonnie Henry when she was in the Canadian Navy, had to learn how to put on a deep sea diving suit and go down to the bottom of the ocean and rescue sailors in wrecked submarines and things like that. So she's quite a colorful character, and I kind of admire her. I admire her career. She's a very impressive woman. The responsibility for paying for the British Columbia healthcare system is shared between the provincial government, which is located in Victoria, and the federal Canadian government, which is located in Ottawa, in case you didn't know where those places are located. So this picture here is simply showing the British Columbia Minister of Health and the federal Minister of Health sharing the expenses of the British Columbia medical care system. Right, so the federal and the provincial governments share the expenses that are needed to finance the Canadian universal single-payer healthcare system, the healthcare system that determines what healthcare system we have in Canada was codified into law in 1984. It was codified as something called the Canadian Healthcare Act of 1984. So you should know, I could ask you on a test about the Canadian Healthcare Act of 1984. It is the original law that defines the healthcare system that we currently use. So, historically speaking, the Canadian Healthcare Act was codified into law in 1984, which defines the healthcare system we have now. I don't know if any of you would recognize who this is, but he was the Prime Minister of Canada. This guy here was the Prime Minister of Canada in 1984. His name was Pierre Trudeau, Pierre Elliott Trudeau. And I don't know if you would recognize this guy at this age, but Pierre Trudeau was Prime Minister of Canada in 1984, and here he is carrying his son, Justin Trudeau. Justin Trudeau is the son of Pierre Trudeau. Justin Trudeau was just the previous prime minister. The prime minister now, at the time I'm making the slideshow, is someone named Mark Carney. But Justin Trudeau was our previous prime minister. Some of you may remember him, and he's actually the son of Pierre Trudeau. Pierre Trudeau is actually quite an important figure in Canadian history. He's many people consider Pierre Trudeau to have been the father of modern Canada. Canada was very much a kind of a small colonial country before Pierre Trudeau introduced a lot of reforms, including the way the healthcare system works in Canada. So Trudeau was Pierre Trudeau was the Canadian Prime Minister when the Canadian Healthcare Act of 1984 was codified. All right, now let's ask the question, because we are interested in the economics of healthcare. Let's ask the question of how efficient is the Canadian healthcare system compared to those of our peer countries. Peer, P-E-E-R, peer means your colleagues or your equivalent comparable countries, right? So the peer countries of Canada would be the United States, Britain, France, Germany, Denmark, any of those Western European and North American places are somewhat similar to Canada in the way they work. And so, how does the Canadian healthcare system compare in terms of efficiency with the other with some of our peer countries? And how can you tell? How do you actually measure this? So let's have a look at that. Okay. First of all, you should, if you're unaware, GDP stands for gross domestic product. Gross domestic product is all of the money that changes hands in a country every year, right? So the size of the economy is one thing, right? So the Canadian economy has a GDP of about 20 what is it? $2 trillion. I'm sorry. So Canadian economy is about $2 trillion. The United States has a population that's 10 times bigger, right? Canada has a population of 35 million. United States has a population of something around 350 million. So the United States has 10 times the population, so you would not be surprised to find out that the United States has more than 10 times the GDP, the gross domestic product. And so the amount of money that changes hands every year in the United States is about 25 trillion, and then in Canada it's about 2.5 trillion. It's about 1/10 as much. Those figures are not exact. And so then obviously the US economy is bigger than the Canadian economy. So if you compare the amount of money that the United States spends on healthcare versus the amount of money that Canada spends on healthcare, obviously it's quite different because the populations are bigger. So instead, why don't we compare the expenditures on healthcare as a percentage of their GDP, which is the normal way that you would do it. So we kind of equalize, we accommodate, or we account for the difference in population size, and we can compare them directly by looking at the percent of the GDP. So what you see here, this type of graph, by the way, is called a bar graph. A bar graph. And we'll be learning how to plot bar graphs in this course. But the bar graph is showing that the United States, now, if I just gave you the numbers, 16.9%, 9.8%, 11.1%, it would be harder to understand. But if you have these bars, and the length of these bars is proportional to the number, then it's easier for people to understand what information is being conveyed here. So what you can see here is that the United States spends about 16.9 or 17% of its gross domestic product on healthcare. The United Kingdom, Britain, spends about 9.8%, Germany spends about 11.1%, Canada spends about 10.1%. So, as a fraction, as a percentage of the gross domestic product, the United States spends about 50% more than these other peer countries. So Canada, our peer countries, you can see that Germany and Britain spend about the same amount of resources, allocate about the same amount of resources to healthcare as Canada does. Canada, Britain, and UK all somewhere around 10%. United States is 17%, which means that it's quite a bit more. So as a fraction of their gross domestic product, the UK, Germany, and Canada spend about the same. United States spends, nearly twice as much. Okay, what if you look at the expenditures per capita? What does per capita mean? So per capita, the word capita literally means per head, right? So the head per person, in other words. Per capita means per person. And because the US dollar is generally stronger than the Canadian dollar or the British pound or the German Deutschmark or anything like that, we this graph, the people who made this graph adjusted it so that to account for the fact that the American dollar is stronger. So all of these, what is the expenditure of all of these countries in US dollars, in other words. Okay, so the per capita expenditures for healthcare in the US is about $9.5 thousand per person per capita. The healthcare expenditures per person in United Kingdom, Germany, and Canada is around 5,000. Right. So again, the U.S. is spending about twice as much per person on healthcare as these other three peer countries. Canada is sort of in line with these other two peer countries, the United Kingdom and Germany. Okay, now when you go to the doctor or you go to the hospital, either the government or your insurance provider pay for most of the costs, but you sometimes end up having to pay for little things, and they call that, you have to pay for this or that. Maybe you have to pay for your meals. They pay for the catastrophic medical care, but you have to pay for the meals, or you have to pay for the bandage or something like that. Sometimes you have to pay for the ambulance ride. And those are called out-of-pocket expenditures. So when you have some medical procedure done, how much of it do you have to pay directly out of your pocket? How much of it do you have to pay directly out of your pocket? So out-of-pocket expenses for the healthcare system in the United States is about $1,000 per person. It's about around 600 for the other peer countries. Okay, so I've demonstrated here that the United States spends more money on healthcare than the peer countries. Canada is sort of in line with UK and Germany and other peer countries in Western Europe. United States spends a lot more per person, or either measured as a fraction of their GDP, or as out-of-pocket expenses, or as uh, uh, purchasing power parity, something called per person expenses, per capita expenses. The United States spends about 50 to 75% more than those peer countries. Does that actually lead to better health? Okay, so first thing is, how are you going to define better health? Well, there's some very common ways that we use to define better health. One of them is life expectancy. Right? So on average, how long do people live in the United States, the United Kingdom, Germany, and Canada? So the average life expectancy is one of the metrics that we measure good health. So you should know that. Right? So if I ask you what are some of the standard ways that we measure whether your health is good, the health of a society is good or bad. One of them is the average life expectancy. So you take all the people and most countries will keep records about how many people died every year and how old they were when they died. So those are called death certificates. So if the government has access to all of these death certificates, all you have to do is add them all up and then divide by the number of death certificates you have, and you get an average. So what is the average life expectancy in these countries? Another common metric that we use to determine whether a country is healthy or not, whether the population is healthy or not, is called the infant mortality rate. Infants are children under the age of 5. In infant and what percentage of them die? Right? So if a country has a large infant mortality rate, it's considered to be an unhealthy population and probably has a poor healthcare system. So we have the average life expectancy, we have the infant mortality rate, we have some other things as well, which I'm going to show you. So how do we measure the outcomes of our various healthcare systems? Okay, sorry. Okay, here is the infant mortality rate. Infant mortality rates are, for the peer countries, infant mortality rates are measured and equalized as the number of deaths per 1,000 live births. So you may be aware of the fact that sometimes a baby is born dead, and so that if that happens, that's called a stillbirth or a stillborn birth, and that is not included in the calculation. That's included in a separate calculation. So here we have the infant mortality rate, deaths per 1,000 live births, and you can see that Canada is higher than it should be, and it is about 5 deaths per 1,000 live births. The United States is even higher. Germany and UK could be better. Germany's better than the UK, but I would say Canada and the United States have work to do to improve our healthcare systems in order to lower the amount of infant mortality. All right, now there's another metric that you can use occasionally to measure to compare the health of various populations, and it is called the YPLL value, years of potential life lost. What you do is you take 1,000 people, and then you take some arbitrary set point for death. Generally, people, if all things are equal and you don't get any, you're not involved in a traffic accident, or you don't catch a catastrophic disease, or you don't have a congenital heart defect, generally a human being should probably live about 80 years. That's an arbitrary number that we've decided on. And if you die before that age, you look at 1,000 people and you ask how many of them died before the age of 80, and at what age did they die. You can calculate the number, what's known as the number of years of potential life lost, the YPLL value. So you can see if you do that calculation, the years of potential life lost for Britons, Germans, and Canadians is about the same. It's higher for the US. Right, so people are dying younger than they should in the U.S. Due to a number of factors. But this is another way to compare healthcare systems. Okay, years of loss for females looks the same. The three peer countries, UK, Germany, and Canada, are about the same. And then the U.S. is a bit higher. So the Canadian healthcare system, we pay the same amount as our peer countries, Germany and UK, for example. And the outcomes are about the same as those peer countries. The U.S. spends more of their money and has less good outcomes. The outcomes are the measurements of how healthy the society is are the numbers are worse, basically. So, is Canada the most efficient healthcare system? No, it's not the most efficient healthcare system, but it's better than some and worse than others. So we have, but these are ways for you to measure and compare different healthcare systems. This is Theresa Tam, who's the public health officer, chief public health officer of Canada, just showing you her picture again. Okay, so this is Mandy Cohen, who used to be, until a few months ago, the head of the CDC in the United States. She's been replaced recently. This is Anthony Fauci, who was the chief infectious disease officer at the CDC for 50 years. He's, in my opinion, a national treasure for the United States. He was one of the best virologists in the world. You'll see him on television occasionally because there's some politicians that are after him for petty reasons. But anyway, he was a good example of a healthcare professional who worked at a public healthcare institution. So here's Anthony Fauci in 1980, and then again in 2023 when he retired. I find this extremely irritating that he looks almost exactly the same. He hasn't aged a day except for his hair getting gray. But he was a superb public health expert a member of the CDC. I will not, by the way, ask you about any of those people, but I will ask you about, give me what are some of the ways that you can compare the amount of money that we spend on healthcare systems, right? So we have the percentage of GDP, the out-of-pocket costs, and the per capita expenditures on healthcare. Those are three ways that we measure how much we spend on healthcare systems. And then how do we evaluate how good they are, how successful they are? And we measure that through the average life expectancy for men and women, the infant mortality rate, and the years of potential life loss. So those are three methods that you use to evaluate how successful the healthcare system is. So I could ask you those questions on an exam. I will not ask you who Anthony Fauci is or who Theresa Tam is, for instance. All right, just for comparison, this is Antonio Guterres is the head of the United Nations. The United Nations is funded by the member countries according to how strong their economy is. As I said, the United States economy is larger than any other economy on earth. Their economy is about 25 or 30 trillion dollars. So that means 25 or 30 trillion dollars changes hands in the United States every year. And so, because the United States has the strongest economy, the largest economy, they pay the most to support the United Nations. You'll see American politicians sometimes throw fits of rage and say we pay the most to support the United Nations. We should have more say in how it's run. But in fact, they do pay more, but the percentage, the sacrifice that they make from their economy is the same as everyone else's, right? All of the countries pay a certain percentage of their gross domestic product to run the United Nations, and so every country is making the same equivalent sacrifice to run that organization. So yes, the United States economy is bigger, but other countries are actually making an equivalent sacrifice as well. And so the United Nations funds the World Health Organization, which is a public health organization that deals with the health of the entire world. We should be aware that the World Health Organization and the United Nations has no power to force member countries to do anything. So occasionally you'll see people that don't know what they're talking about saying, oh, the World Health Organization is telling us to get vaccinated and things like that. It can't. It does not have that power. So any time that a country does something that the World Health Organization recommends, they're doing it on a voluntary basis because neither the United Nations nor the World Health Organization have the power to tell a member country to do anything or to not do anything. So, as I said, the member countries support the United Nations and therefore the World Health Organization by donating an equal percentage of their gross domestic product, their GDP. Who pays the most and who pays the second most? Well, you can probably guess. As I said, the United States has the largest economy, so the United States does pay the most. The second largest economy in the world is China, so China pays the second most. And in fact, the Chinese economy is only about half the size of the United States economy. So the United States pays twice as much to support the World Health Organization as China, and then China pays much more than Canada and so forth. Canada is quite far down the list because we have a very small economy. All right, this is the actual contributions to the World Health Organization. So you can see the United States donates about $110 million every year to the World Health Organization. China about 60 million. Canada doesn't even show up on the list because our economy is very small because we have a very low population. So here is the World Health Organization, and it is located in Geneva, Switzerland. And there's the head of the current head of the World Health Organization there. And as I said, the World Health Organization has no power to force member countries to do anything, no power to enforce vaccine mandates or anything like that. Now, usually it is generally the rich developed countries that pay for the World Health Organization, but the information and the services that come out of the World Health Organization are usually used by poor countries, right? And so there are many politicians who say, well, that's not fair. We're paying the most to fund the World Health Organization, but we're not using it. So why should we have to pay this much? Well, the reason for that, my personal answer to that, you may have a different opinion, but my personal opinion for that and the view of the public health community is that pandemics, disease outbreaks tend to start in poor countries. They tend to start in poor countries and then spread to other countries, to wealthy countries as well. The reason they start in poor countries is because the poor countries have public healthcare systems that are underfunded and have limited ability to stop epidemics and outbreaks. So sometimes the World Health Organization comes into a poor country and tries to help them control an outbreak of a dangerous disease before it has the chance to spread. That's one of the main things that the World Health Organization does. And because diseases don't respect national borders, national boundaries, uh, it makes sense for the wealthy countries to pay to stop epidemics when they start in the poor countries, because then that prevents them from spreading to the wealthy countries. So pandemics do not obey national boundaries. The analogy I like to use is, imagine your house is on fire, or imagine somebody's house is on fire. Right? So you have a lovely house that you spend a lot of money on. The person next door didn't spend as much money. They didn't buy smoke detectors. They do some irresponsible things, and their house catches on fire. And you say, well, they were irresponsible. They didn't buy smoke detectors, and they did a lot. They had illegal wiring and things like that. It's their fault that their house is burning. So you can make that argument, but the analogy is that, what difference does that make if their house sets your house on fire? So it is in your interests to help your neighbor put out their burning house, because that's a way of preventing it from spreading to your house. That is sort of the way communicable diseases work, and that's sort of the philosophy behind the World Health Organization, and paying richer countries, wealthier countries, paying money into the World Health Organization so that they can then use those resources and that money in countries that have underfunded healthcare systems. All right, these are just some of the people that run these different organizations. You don't. I will not ask you about these. But I may ask you multiple choice questions about the organizations, like which of these organizations spends the most on healthcare research, which of these spends the most on doing experiments and designing public policy that's intended to stop the spread of disease. Where are they located, right? Like, which of these organizations is located in the United States? Well, the answer is the CDC. Which of these is located in Switzerland? It's the World Health Organization. Which of these is located in Ottawa? It's the Public Health Agency of Canada. Ottawa being the capital of Canada, of course. Which of these is located in Vancouver? Well, it's the British Columbia Center for Disease Control, which is located in Vancouver. I could ask you those types of multiple questions. Which one of these organizations has the largest budget? Which one has the lowest budget? And so forth. All right, we've been through this a couple times now. We know the difference between epidemiology and public health. And so epidemiology is the study of the causes, the determinants and distribution of illnesses within a population, not individuals. And it's basically a marriage between pathology, which is the study of disease, and demographics, which is the study of populations, groups of people, and geography with the landscape. So where are the sick people? Where do they live? What part of the landscape do they occupy? Public health has to do with government policy. So let's take a look at the history of public policy and epidemiology, but public health in general. Some historical examples that shaped the science of health sciences that we know today. Let's look at the history of the human race and its interaction with disease. So let's be tourists, and let's just have a tour through the history of public health.